Good evening, ladies and gentlemen. My name is Ziting Lee. I'll be your moderator for this evening. And I'd like to welcome you to the ANZSNM 2020 virtual meeting, zooming from the Austin Hospital here in frosty Melbourne, with a live audience in attendance for the Pioneer Lectureship, fully compliant with the social distancing among this COVID-19 pandemic. Before I introduce our esteemed speaker, may I please remind everyone that the Attendo Plus app is available to record your attendance as seen here, and I will leave this up for a minute. The ANZSNM Pioneer Lecture is for the leaders of our profession who have demonstrated significant contribution to the field, and our invited Pioneer Lecturer for 2020 exemplifies this. It gives me great pleasure to introduce our Pioneer Lecturer at this inaugural virtual annual scientific meeting, Professor Chris Rowe. Professor Rowe was identified by the Australian in their 2019 survey of the Australian research as the field leader for neurology. He is a nuclear medicine physician and neurologist, dividing his time between clinical nuclear medicine, dementia care, and research. He is the director of the Australian Dementia Network, ADNet, established across the nation in late 2018 at 11 universities and research institutes with funding from the NHMRC, National Institute of Dementia Research, and philanthropic donors. Chris is also the Director of Molecular Imaging Research at Austin Health and the University of Melbourne. Although his nuclear medicine research career started in epilepsy with his MD thesis, pioneering the development of post-ictal and ictal SPECT for seizure-focused localization, his research focus later shifted to molecular brain imaging of neurodegenerative diseases, particularly Alzheimer's disease, for better understanding, earlier, more accurate detection, and to facilitate development of early therapeutic interventions. In this area, he has been extremely productive and has consistently been a highly cited researcher, top 1% worldwide for neuroscience since 2016, averaging over 4,500 citations and 20 publications a year, and has received international awards including the US Society of Nuclear Medicine Kuhl-Larsen Award for Outstanding Contribution to Brain Imaging and the Christopher Clark Award for Advancing Human Amyloid Imaging. In total, he has over 350 publications and has received research funding of over $38 million from the NHMRC and $17 million from other sources. His current focus is on translation of recent advancements in diagnostics for Alzheimer's disease into clinical practice, facilitating clinical trials to prevent dementia, and establishing mechanisms to ensure high-quality dementia diagnosis and care. He leads the research teams at Austin Health and University of Melbourne and has a strong record of national and international collaboration in this space. So without further ado, I'd like to invite Professor Rowe to come up to give his Pioneer Lecture. Thank you.
Thank you, Ziting. I couldn't have written something better myself, which I did, of course. I'm very pleased to give my first ever virtual lecture here at the 50th meeting of the ANZ Society of Nuclear Medicine, and certainly want to thank the organisers for inviting me to give this prestigious presentation. This is a highlight lecture. It has been for a long time, and it's certainly an honour. One of the great things about this lecture is that I can talk about my favourite subject, and that's me. Now, if I get too self-indulgent, Ziting has been told to intervene. So for the first 10 minutes or so, it's going to be a trip down memory lane and fairly self-indulgent, but then we'll get into a little bit of true science in nuclear imaging. So in the beginning, there's me in primary school, and then later on the last day of medical school, I went to Flinders Medical Centre in Adelaide, and you have to pick which one's me. Yes, I had a lot more hair back in those days. Anyway, from completing medical school, I moved to the Austin Hospital as an intern, subsequently did general physician training. And then while having to fill in a year waiting for a position to come up as neurology registrar, I took a year of shared nuclear medicine and stroke registrar. And that's where my beginnings in nuclear medicine occurred. This was the stroke team back at the time. So around this period in the late 1980s, overseas PET was starting to show potential for clinical applications. So remembering this is back in the days before MRI, and it's before the days of oncology PET. So it was all neuro PET, and initially it was a lot of very basic research. But then researchers, epileptologists and nuclear medicine physicians at the University of California, Los Angeles, found that hypometabolism was present in the temporal lobe of people with temporal lobe epilepsy. And this could help localize the seizure focus prior to surgery to resect the abnormal area. And that reduced the reliance on previously necessary intracerebral electrode recording. So instead of poking electrodes into people's brains, you could do a PET scan and combine that with surface EEG and a few other investigations and go to successful surgery. Now, Austin Health at the time was one of only two and was probably the leading epilepsy surgery centre in Australia. So a lot of talk began about the need for a PET scanner in Australia. Also around this time, the characteristic abnormality was identified in Alzheimer's disease on PET studies of glucose metabolism. And here you can see the temporoparietal hypometabolism we know well today. In 1983, the first neuroreceptor study was done. It was done on Henry Wagner, who some of you may know. He was referred to as the father of nuclear medicine. He was head of the nuclear medicine department at Johns Hopkins. And this is in fact his brain. He experimented on himself in the tradition of all good researchers. So this caught my interest. And so as I was doing my neurology training, I decided I'd move into a crossover with nuclear medicine. And the area that really popped out was the potential to use cerebral blood flow imaging with Ceretec for seizure localization. So Ceretec was just introduced into Australia at this time, and there'd be one minor report from a site in the US talking about injecting people during seizures. It only had 4 people in that report. So I decided to make it the subject of my thesis for Doctor of Medicine. So during my neurology training, I was running down to the nuclear medicine department, quickly mixing Ceretec with technetium, running back up to the seizure monitoring unit and injecting the patients. My average time from seizure onset to injection was about 4 minutes. But then became evident that the earlier you injected, the better the results. And so we eventually trained up nursing staff to do the injection as soon as seizure became apparent. So this is my thesis. It's a Doctor of Medicine thesis, which is equivalent in the British system to a PhD. In fact, it used to be regarded as higher. Of course, now that's been eroded by University of Melbourne, making every medical graduate a Doctor of Medicine. But let's just say it's a good thing, a good degree to have. These are some of the publications that came out of this work: Annals of Neurology, Lancet, Neurology, and Journal of Nuclear Medicine. So it was an extremely successful piece of work. You'll notice in the acknowledgements certain names there that may seem familiar. John Mackay, who was the Director of Nuclear Medicine here at the time and for many years after, and then used to move to Monash. Mark Austin, who was one of the technologists who helped greatly with the acquisitions, and Gordon Chan, our radiopharmacist, who many of you will know. So I guess this is the highlight image out of that thesis. It's the same person imaged 3 times, interictal blood flow, not really showing much between the right or left temporal lobe. Then an injection during a seizure, and you can see that right temporal lobe lighting right up with marked hyperperfusion and some reduction in other areas of the brain, including the other temporal lobe. And the patient also had a post-ictal seizure where they were injected 4 minutes after a seizure. And you can see that by this time, the hyperperfusion is restricted, if I can get the arrow up, to this medial temporal area. And there's this striking reduction, what I termed surround inhibition. around the seizure focus. So on a post-ictal scan, you can localise a seizure, but things look much more dramatic if you actually capture the ictal focus. So I completed my neurology training. I had a bit of nuclear medicine under my belt. I'd done my MD thesis, and then I decided to head off to America to study PET. So I went to various centres, including Johns Hopkins, etc., interviewed with various people, and got the most welcoming response from Washington University in St. Louis. Now, this was a leader at the time. It was one of the places that PET imaging scanners were developed. So I went there for a year to complete my nuclear medicine training, and then had an NHMRC Neil Hamilton Fairley Fellowship to study PET imaging. That work was done in baboons, looking at cerebral blood flow, and was certainly an interesting time. St. Louis is famous for its arch. This is about the only major tourist drawcard in St. Louis. There's actually a little train inside of it that you sit in, these tiny little capsules, and it takes you up to the top where there are lookouts. So I did that about 5 times every time we had a visitor to St. Louis. It was into the arch again. Now, after a couple of years in St. Louis, which I must say were very enjoyable, I strongly recommend spending time overseas to people once they finish their specialty training. I was sitting there and was thinking, I'm really not terribly interested in blood flow imaging in baboons. And a colleague who'd moved to the Queen Elizabeth approached me about a job there. I said, no, I don't want to go to the Queen Elizabeth. Going back to Melbourne, going back to the Austin. And he came back and said, well, come on, what will it take? So I made a list of about 15 requirements, including that they purchased the first multi-head SPECT camera in Australia. Now remember, this was pre-PET, so this was leading state-of-the-art nuclear medicine imaging. I also made a few other demands. I wanted to do 2 days of clinical neurology. I wanted to be paid quite well, etc., etc., etc. Surprisingly, I said, okay, yes, we'll do all that. And so, somewhat unexpectedly, we were on a plane to Adelaide. And that's where I spent the next 9 years, and they were very enjoyable 9 years. You can see Michael Kitchener, who was the other nuclear medicine consultant there. He was a VMO who was there 2 days a week. I was there full time. There's the Trionics triple head SPECT camera, which did great. I must say, probably still better than SPECT studies are done today. It had fan beam collimators and a good tight rotation. Another major asset of the Queen Elizabeth Hospital was Leighton Barnden, who's a medical physicist also, who was known to many of you, and we did some very interesting work together. In fact, some of the work we did on fibromyalgia, looking at blood flow imaging and changes in patients with fibromyalgia, Leighton's carried on with to this day. He's currently up in Griffith University working in that field. I formed a very useful and productive collaboration with ANSTO, with two young chemists there at the time, Andrew Katsifas and Michael Cassio. At that stage, ANSTO had a big cyclotron that was producing all the thallium, gallium and iodine 123 for Australia. Unfortunately, that facility was subsequently shut down. But while iodine 123 was available, we did some interesting work with compounds such as IDEX, which labels muscarinic receptors. And this is some work we did in temporal lobe epilepsy at the Queen Elizabeth. There's an interictal study, an ictal study showing the hyperperfusion in the left temporal lobe. But on the baseline, the interictal study, you can see a dramatic reduction in cholinergic receptors, much more obvious than any reduction in blood flow. So it was actually quite a nice finding. We also did some work in Alzheimer's disease and showed some changes there. But this compound was not readily available, and so it didn't catch on widely. So the Queen Elizabeth team were a really nice bunch of people. They even threw a party for me on my 40th birthday. There's a few familiar faces here. Steve Unger, many of you will know, who subsequently became director after I left and is there, and at Lowell McEwen. The infamous George, Peter Roselt, radiochemist, Piao, Tess, and hiding in behind there is Jenny, who some of you may know. So in 2000, though, I moved back to the Austin. There are a number of reasons. People move for you need a bit of a push and a bit of a pull to make a big move. The pull was the fact that John Mackay was moving to Monash, so it created a position at what was clearly the leading nuclear medicine department in Australia at the time. At that time, there were only 3 PET cameras in Australia, one at the Austin, one at Royal Prince Alfred and one at Peter Mac, and the only hospital that had its own cyclotron was Austin Health. So it was the place to be if you wanted to do really state-of-the-art nuclear medicine research. We can see the famous David Thomas, who was one of the technologists at the time. That was the old Siemens ECAT PET camera. And here's Henry Touchon-Donguet, who was the head of radio chemistry, and the old cyclotron that was installed in 1992. So not only did it have good equipment, but it had good scientific support staff. So there was Henry, there was John Sachanides, another senior radio chemist, the infamous Gordon Chan, who many of you all know, who was the radio pharmacist, and our physicist, Graham O'Keefe. And we were dabbling in a number of areas. Up until 2004, we looked at dopamine receptors, nicotinic receptors, activated microglia, serotonin, benzodiazepine, and some hypoxia work. But things changed after 2004. Now, what changed? Well, I started a collaboration with Colin Masters at the University of Melbourne, the Florey Institute. He was probably still is, the leading Alzheimer's researcher in Australia. And I attracted Victor Villemagne, who is a graduate in nuclear medicine from Argentina, but had done 10 years of PET research in the United States and was in Spain. And I was told by Michael Cassio, the radiochemist I mentioned earlier, that Victor was looking for a job and he was an extremely intelligent and capable person. So we persuaded him to move to Melbourne. And then opportunity really knocked. So I had trouble getting Colin Masters interested in PET. I went to him one year and said, look, we can look at nicotinic receptors. And he went, oh yeah. Then I went back a year later and I said, we've got to be able to do something together. PET and Alzheimer's are in such a natural fit. And he said, well, can you do this? And he showed me a picture from a publication from the International Conference of Alzheimer's that year, which was the first image of amyloid plaques in the brain performed with PIB. And I said, that looks fantastic. Let's get it. So then came the hunt. So I was giving a talk at Johns Hopkins about SPECT, and I saw that Chet Mathis, the radiochemist that developed PIB, was also on the program. So at the end of his lecture, I fronted up to him at the front of the lecture theatre and said, hi Chet, I'm Chris Rowe, I'm from Australia. I'd really like to get access to PIB. Spoke to him for a while. And Americans do like Australians. We're not competitors. We're not a threat. We don't compete for their research funding. They like us. They think we're all like Crocodile Dundee. And so I got a warm response. He said, well, we'll have to discuss it with Bill Clunk. So I subsequently, in a later visit, went up to the University of Pittsburgh, met the whole team up there. And they said, well, yes, Chris, we think we would like to support you and you can have some PIB. Then the lawyers stepped in. The Pittsburgh lawyers said, no, you cannot give precursor and standard made in this university to other people. They gave me some anyway. I brought it home on the plane and we started developing the techniques for making PIB. We then identified an alternate source from a radiochemist called Alan Wilson in Toronto. He'd made PIB for a short study there, and they were actually the second site in the world to do PIB. But in a remarkable example of lost opportunity, they didn't follow on. They did about 15 scans and that was it. So he was left with a whole lot of PIB sitting on the shelf that he couldn't do anything with, and he was happy to share it. So we got it sent here. We got the synthesis working. I then applied to the NHMRC for a grant, and like all good ideas, it was unsuccessful. Now, this is a sure sign of success. If your first approach to NHMRC is not successful, take heart. Nobel Prize winners did not get NHMRC funding on their first attempt. We got some seed funding from the local Austin Health and Medical Research Foundation, and away we went. And on the chart, we were the 7th site in the world. So by September 2004, we were up and running with PIB. And we ran hard. So by 2007, we had enough for a good publication comparing patients with dementia with Lewy bodies, Alzheimer's disease, frontotemporal dementia and healthy controls. We were able to show the differences between frontotemporal dementia and Alzheimer's disease, which, as you can see, is incredibly stark and not surprising because frontotemporal dementia patients don't have amyloid plaques. We showed for the first time that dementia with Lewy body patients have a similar pattern to Alzheimer's disease, and you do find amyloid plaques in about 50% of those cases. That was one of the first major papers on PIB, and it's had over 1,200 citations. Another big factor that then occurred was the formation of the Australian Imaging, Biomarkers and Lifestyle Study of Ageing in 2006, initially with $1 million a year for 3 years from CSIRO, and that turned out to be incredibly fruitful. It brought together leaders in Perth and Melbourne into a study that's been fantastic in its productivity and success. Another major breakthrough came in for us in 2006 at a Society of Nuclear Medicine, or 2007 in Society of Nuclear Medicine meeting. And this is why you need to travel. If you want to be successful and have an international profile as an Australian, unfortunately you have to travel. You have to go to conferences, you have to meet with colleagues and establish collaborations. So at the time, there was an association with Australian neurologists and Schering, who were a Berlin-based pharmaceutical company, who made a lot of imaging agents for MRI and CT. They were interested in developing PET ligands. A small company had been formed, a spin-off from the University of Pennsylvania by a neuropathologist called AVID had been formed, and a radiochemist there called Hank Kung had developed some compounds that appeared to label amyloid, and they were labelled with F18, which is a major advantage over PIB with its short half-life carbon-11 label. They wanted someone to try it. So Schering, which had been bought out by Bayer at their stage, said, okay, we will pay $1 million to have first rights to evaluate this in humans and decide if we want to buy it off of you. We sat down together. They said, Chris, you've got a PET camera and things, and we know you from some work we've been doing. Let's meet with the AVID people and see what we can do. So I think it was in Toronto, we sat down and it was decided that we would do the first in human studies. So we quickly did them. We were published in Lancet Neurology. We showed that the tracer worked. Bayer subsequently bought that tracer from AVID. It was at the time called AV1 because it was their first compound. AVID then turned around and said to Bayer, well, we've got lots more amyloid imaging compounds. Do you want to buy those too? And Bayer said no. So AVID checked some of them out themselves, and one of them, AV45, looked promising. So they ran with the development of that themselves, actually in competition with Bayer. And being a small, agile company, they did it faster. So AV45, known as florbetaper, got to the market first. They were then bought out by Lilly, who needed an amyloid imaging agent for their anti-amyloid drug trials, for a price that was in excess of several $100 million. So there's another lesson. If you can spin off a company, do it, because it can be quite rewarding, although hard work. We have also been very involved in the development of tau imaging. We've done this in collaboration with Tohoku University in Japan. And so this was a presentation we gave at the Alzheimer's Association International Conference back in 2012 on the first of the compounds that appeared to show some specific binding to tau. That particular compound didn't work out in the long run, but it did pave the way for subsequent successful development of tau imaging compounds. This is the current neuroscience team at the Austin. There's a few familiar faces in there, and I just particularly want to point out Lana, our Chief Coordinator and Research Nurse, Rachel Mulligan, our Chief Radiochemist, Reagan, Sihar, particularly Jess. She's been our lead technologist, research technologist since day one, and still plays an active role in our scanning. Over here we've got Kenneth Yap, radiopharmacist, and Gordon Chan, and several other important members of the team, and Victor Villemagne, who's still with us. So, as in the introduction, this has been an incredibly productive period. I'm quite amazed by how successful it's been. I was pretty shocked when the Australian named me the research leader in 2019 in neurology. I suspect most neurologists don't even know who I am. I have been a highly cited researcher, that's top 1% in the world, since 2006 every year in the field of neuroscience. And there's only 4 Australians that are in that category. I have over 350 publications and a total of over 36,000 citations. So the work we've been doing has been noted and proven important. Citations are the major metric that's used to assess the impact and significance of your research. NHMRC funding has just continued to grow to an amazing total of 38 million, and I've had funding from other sources in excess of 17. Here's a picture of me getting the Christopher Clark Award in Miami back in 2015. I'm shaking hands with Cliff Jack. We were co-awardees that year. If anybody knows Cliff Jack, he's an absolute powerhouse from the Mayo Clinic and an absolute leader in the field of MR and other. And subsequently, they came later on. I actually went there and told them about. I gave a lecture at the Mayo Clinic and showed them how good PIB was. And shortly after that, they introduced it. And it's a powerhouse now of nuclear medicine as well as MR research. Now, here's my recommendations for a successful academic career. Firstly, have a supportive partner. So I have to thank my wife, Karen, who's not only been a fantastic support on the home front, but has also assisted me over the years with contracts, management, and other important aspects of my research. This is us doing the Tour de Mont Blanc last year, where we just completed a fairly high climb, looking quite self-satisfied. Now, work with people smarter than you. There's no doubt that Victor Villemagne and Colin Masters are smarter than me. I used to make a joke that Victor did all the work and I took all the credit, but more recent years, Victor's had plenty of credit as well and is now, in fact, too much, because he's unfortunately been offered a great job in the United States and is leaving us. You must collaborate, you must share data and do it freely. Don't be possessive of your data, and travel. If you're an Australian, as I said, you have to travel. You have to go and see people. You have to meet with international companies. You have to collaborate. But most of all, you have to be persistent. I've got where I've got by persistence, not by brilliance. As Thomas Edison says, success is 90% perspiration, 10% inspiration, and there's no doubt about that. Now, I must also point out that the department here at Austin has been thriving not just in neuroscience, but in many ways. This is some of the team who you will recognise. We've got Kunthi, we've got Sam Berlingeri, Ziting, of course, who all of you will know, Andrew Scott, who all of you will know, who's been a previous recipient of this award, and Sylvia, one of our physicists. We've had a new cyclotron installed over the journey. We now have 3 PET-CT cameras, and we've even got capacity for doing PET and SPECT in animals. So it's been a great career move coming to the Austin. It's been a time of boom for nuclear medicine in general. And as I said, I'm going to keep talking till there's nobody left in the room. Now to the lecture. So Alzheimer's disease. Correct diagnosis and prognosis of the dementia is hard. The current clinical criteria, so if you go and see a specialist today in Australia, they'll use these criteria, and they've been repeatedly shown to only have about 70% accuracy for the diagnosis. And that's been also shown in people then volunteering for anti-amyloid trials with a diagnosis of Alzheimer's disease. 30% of them don't have any amyloid in their brain, so by definition do not have Alzheimer's disease. The other problem with current clinical diagnosis is you're not supposed to make it till the patient's demented. That means they're dependent on other people for daily activities. Whereas people have symptoms for 3 to 5 years before they get to that stage. So officially, you're not allowed to give them a diagnosis until they're demented. Not good. It's like telling somebody with chest pain, well, the diagnosis is chest pain. Could be a muscle strain, could be cancer. We'll just have to wait and see. When you're in that what's called mild cognitive impairment phase, so you do have memory and other problems, your tests are abnormal, but you're still coping normally with life, you're left in limbo. There's about a 50% chance of people with this condition progressing to Alzheimer's dementia. About 15 to 20% will have another sort of dementia developing, but importantly, up to 40% never develop dementia. Treatment of dementia is even harder. You've probably heard that 99.9% of Alzheimer's trials have been unsuccessful in trying to modify the course of the disease. And there is currently no treatment available that does prevent or alter the course of the disease. So we need to understand Alzheimer's more. Doesn't mean we give up, we keep trying. And actually, thanks to amyloid imaging and PET, there is now actually real hope that we might have a disease modifying treatment, but I'll mention that a bit more later on. Molecular imaging plays a big role then in dementia because it can improve diagnostic and prognostic accuracy and assist better understanding of Alzheimer's disease and other dementias, and also help with drug trials and evaluation of therapies. FDG, I'll just quickly run through. Many of you will be aware of the typical pattern of parieto-temporal and posterior cingulate hypometabolism. Hopefully many of you are aware of Neurostat, where you take an individual scan and compare it to a normal age-matched database, and it shows you areas of the brain that are statistically abnormal. So in this colour scale, it's showing Z scores or standard deviations where the brain, in that bottom row, where the brain is below normal in metabolism. And this technique does definitely improve the performance of FDG PET above visual reading. In fact, I would not advise anyone to attempt to read an FDG brain PET for Alzheimer's disease without employing one of these quantitative database comparison programs. And they're available from multiple vendors. And this is just showing how Neurostat studies with Neurostat, each individual dot point is a study, have outperformed visual reading of FDG for distinguishing Alzheimer's disease from healthy controls. And it also tells you a lot about other diseases other than Alzheimer's disease. This is one of my favourite slides that I've made. It shows the typical distribution of the common forms of dementia. So Alzheimer's disease, the language onset form of Alzheimer's disease called logopenic aphasia, dementia with Lewy bodies, where you also get involvement of the occipital lobe and sparing of the posterior cingulate, the behavioural subtype of frontotemporal dementia, a non-fluent aphasia subtype of frontotemporal dementia, and the semantic language subtype of frontotemporal dementia. Now, it's been known for quite some time that FDG PET outperforms clinical diagnosis when a patient first presents. So clinical diagnosis made at a clinic in San Francisco. It was an expert memory disorders clinic. Compared to post-mortem, that initial assessment was only 76% accurate, or 76% sensitive and 58% specific, whereas PET done at the time was 84% and 74%. We've done management impact work here and shown there is significant management impact from FDG. It changes diagnosis to a significant degree, and from neurodegeneration to depression, basically, or vice versa, in about 7%, and changes medication and dementia type in about 37% of patients. But PET has limitations. Hypometabolism does reflect the clinical deficits, so the findings are relatively subtle in mild cognitive impairment. Changes are less clear in the very elderly, and the sensitivity and specificity is still not perfect. But now with PET, we can look at Alzheimer's pathology. So amyloid plaques, and more recently, tau tangles or neurofibrillary tangles. So here was that paper I mentioned before, showing the patterns that are specific for different types of dementia with amyloid imaging. The F18 compounds have been developed and they show sensitivity and specificity compared to post-mortem, greater than 90%. There's now a new standardised way of interpreting amyloid scans quantitatively. It's called the Centiloid scale, and it's like the Celsius temperature scale from 0 to 100. 0 is no amyloid, 100 is the amount of amyloid you expect to find in a typical patient with Alzheimer's disease. And any amyloid scan can now be put on that scale. We and others have shown that less than 15 centiloids means your brain is free of amyloid. More than 25 means you've got a significant amount of amyloid. More than 50 means you've got enough disease to cause Alzheimer's disease, Alzheimer's dementia. These sort of advances have led to new criteria for diagnosis of Alzheimer's disease. So this was in 2004 from an international group of experts, and it determined that if you had a memory problem, you didn't have to wait for dementia. If you had a positive amyloid scan or positive CSF analysis for amyloid, you could make a diagnosis of Alzheimer's disease at that stage. So before the dementia phase, and with much greater accuracy than clinical diagnosis. Very recently, another factor has been thrown into this diagnostic system. It's called the ATN, stands for amyloid, tau, and neurodegeneration. Use amyloid PET or CSF. Use tau PET or CSF for the amyloid and the tau. And the neurodegeneration, you can use MR evidence of atrophy of the hippocampi or FDG evidence of hypometabolism. And that's leading to even more specific diagnosis. These techniques are expensive, so there have been appropriate use criteria set for PET, and these should apply to FDG PET as well. You don't need to do these expensive scans in absolutely typical, straightforward patients, but they are useful particularly in those with early onset, that is under the age of 65. The clinical features, the MRI findings, the neuropsychology findings are often atypical. There's often a lot of psychological and psychiatric overlay. In mild cognitive impairment, these techniques can help you tell who's really on the road to a neurodegenerative problem, and can help you actually give a pretty accurate prognosis of when they'll have dementia. And dementia of uncertain cause after experts really haven't been able to decide. That's when you should use these types of investigations. There's been a study in the United States called the IDEAS study looking at the management impact of amyloid imaging. It was in 18,000 people from clinical practice, and it showed an enormous impact on change in drug usage. It showed that clinical diagnosis didn't correspond to amyloid imaging terribly well at all. Only 61% of those that came with a diagnosis of Alzheimer's disease had a positive amyloid PET scan, and 55% of those that came with a diagnosis not of Alzheimer's disease had a positive PET scan. So after the PET, diagnostic changes were pretty profound. Those with a positive scan went from 78% to 95% with diagnosis of Alzheimer's, and those with a negative scan dropped from 73% not Alzheimer's disease to 15%, not Alzheimer's disease. We can look at some other conditions indirectly, alpha-synuclein related neurodegenerative conditions like Parkinson's disease and dementia with Lewy bodies and multi-system atrophy. The abnormal protein is alpha-synuclein. The Michael J. Fox Foundation has had a $2 million prize to the first group or person that can develop a radio tracer for alpha-synuclein. That prize has gone unclaimed for the last 5 years or more. It's proving a difficult target to image. But we can look at the effect it has, the effect of alpha-synuclein and Lewy bodies has on the nigrostriatal pathway. So the dopaminergic neurons that go from the substantia nigra in the midbrain up to the striatum, which is the putamen and caudate nucleus. Because on the end, in the terminals, you have dopamine transporters and vesicular monoamine transporters. So if these neurons die off, the concentration of those transporters decreases in the striatum. And DAT scanning, which has been available for over a decade in Europe and the US and is strongly recommended for assistance in diagnosing Parkinson's disease and dementia with Lewy bodies, has been shown to be markedly superior to clinical diagnosis, particularly for dementia with Lewy bodies. This was compared to post-mortem. These are the sorts of images we get with vesicular monoamine transporter imaging. So healthy control there. Alzheimer's disease look the same because they don't lose dopaminergic neurons. But then dementia with Lewy bodies and Parkinson's disease, you can see a dramatic loss there, particularly in the putamen part of the striatum. So clinical application, PET can determine the underlying pathology in a patient, can clarify the diagnosis and prognosis in a particular patient, and it can direct the patient to the most appropriate therapy and to early intervention drug trials. We now have a host of potential, at least in research sites, ligands that we can use. A little bit about research. So I mentioned the ABLE study. The ABLE study has uploaded the first 6 years' worth of data onto a website called LONI. And that's been accessed by over 4,100 researchers from these countries that are all shaded in orange worldwide. So this is the way the world is going. Everybody is sharing data. The Alzheimer's Disease Neuroimaging Initiative also shares its data through this mechanism. The NHMRC has been discussing whether to make data sharing compulsory or not. You can't get an NIH grant in the United States now unless you agree to share your data. You can embargo it, you can hang on to it for a year or two after you've finished your study, but then you have to let it out to the world. Some of the information we've obtained from ABLE, we're looking at what proportion of the population have a positive amyloid scan by age. So basically, if you're in your 50s, you've got a 5% risk of having a positive amyloid scan. It goes to 10% in your 60s, 30% in your 70s, and 50% by the time you've hit 80 to 85. Now, these numbers, actually, if you slot them in with what pathologists know about how frequently you find amyloid plaques at post-mortem by age and the prevalence of Alzheimer's disease dementia by age, suggests that the amyloids, or suggested at the time, the amyloid imaging was picking up patients about 15 years before development of dementia. And subsequently, we've proven that to be true. We've also proven from serial data, these are repeated amyloid scans done every 18 months in the ABLE cohort, we've been able to work out the rate at which amyloid is accumulating. So it's in fact 4 centiloids per year. So this is on that scale that goes from 0 to 100. At 25 centiloids a scan becomes abnormal. When you look at it visually, you can think, that doesn't quite look right. I think there's a bit of amyloid there. So that's the traditional threshold for a positive scan. To get up to 100 centiloids actually takes 20 years. Below the threshold, we can see that to get down to 0 centiloids is probably about 10 years. So over 30 years, amyloid is accumulating in the brain. Amyloid plaques are accumulating in the brain before you develop Alzheimer's disease dementia. So it's an incredibly slow process. So it tells us that whatever's going wrong is pretty minor. And we think it's a breakdown, a slowing of clearance of just 1% or 2%. Some people are just predisposed to clearing amyloid out of the brain a bit more slowly than others. There's some strong genetic factors such as ApoE4 involved in that. And there's lifestyle and environmental factors that play a role. But just that tiny difference results in Alzheimer's disease in your later life. Looking at healthy controls, this is over 530 healthy controls aged over 65, and we looked at how much amyloid they had in their brain, dividing it up by centiloids, and this is their risk. This is called a survival analysis. So it's progressing to mild cognitive impairment from being a normal, healthy older person with normal cognition. And you can see it's really reflected by how much amyloid you have in your brain. If you have a brain chock full of amyloid, even though you're normal at the time, you've got a 60% chance of developing mild cognitive impairment within 4.5 to 5 years. If you've only got a mildly positive scan, then you're still going to be okay for 5 years, but then by that time your amyloid level's gone up into a higher bracket and your risks of decline are much higher. And if you have less than 25, well, really you're looking at quite a long period without any significant decline. And if you look at a test of memory, this is how many words you can recall from from a list of 16 words after being trained over a few times. The green and the grey are like what happens if you've got less than 25 centiloids worth of amyloid. And actually you improve over time because you get a bit of practice. This is doing this every 18 months. If you've got a lot of amyloid, well, you decline. Fair bit of amyloid, this is 50 to 100 centiloids, you're declining. And you've got a little bit, you're declining, but not much. This is useful when selecting people for anti-amyloid trials in normal older individuals. There's no point putting people into a trial who aren't going to show a decline if your outcome measure is going to be slowing decline because they're not declining. So it's a very important role that's emerging for amyloid imaging. Well, likewise, the rate of conversion from mild cognitive impairment to Alzheimer's disease depends on how much amyloid you have in your brain. Those with no amyloid, actually over a 4-year period, don't progress to dementia. You can see with high amyloids above 50, it's a fairly rapid progression rate to dementia. And if you're just mildly positive, then there's a bit of an in-between risk of progression. Tau imaging. This is relatively new. We've got an amyloid scan done with NAV4694 and a tau scan done with MK6240. In my opinion, these are the best amyloid and tau agents currently available, and we've been running hard with these now for quite some years. You can see the tau accumulation is somewhat different to amyloid accumulation. You get a lot of frontal amyloid, but tau tends to be more the posterior parts of the brain and temporal parts. We've been looking at trying to time amyloid accumulation versus tau, because the theory is that amyloid comes first, and then it does something that triggers tau formation, and then the tau formation destroys cells and impairs cognition. So this is paired scans in individuals, and they're ranked by how much amyloid they've got in the brain. So if we look at the amyloid scan, we're now up to about 30 centiloids. You can see it's clearly positive, but the tau's not really starting to build up till we're about 40 or 50 centiloids. And then the tau really sort of starts catching up with the amyloid. So it does fit with the hypothesis that amyloid comes first. Therefore, if you can take amyloid out of the brain, there's still a hope you'll stop the downstream effects, the tau formation, the cognitive decline. Not everybody that's amyloid positive and has dementia and a clinical appearance of Alzheimer's disease actually has Alzheimer's disease. So these are some Alzheimer's cases. They were all amyloid scan positive. They all were clinically diagnosed as Alzheimer's disease. But here we have 2 cases who don't have any tau in the brain. Turns out this one has got bilateral cerebellar infarcts from atrial fibrillation that had gone unnoticed. And the cerebellum actually does play a role in cognition. So this is called the cerebellar affective cognitive disorder. So we think that's why this person's got a bit of amyloid. He's got amyloid plaque, so he's on the road, but most of his cognitive problems are probably due to vascular disease. This person, who is 88, has very severe hippocampal atrophy. We now recognise a condition called late, limbic predominant, age-related TDP43 encephalopathy. It's not Alzheimer's disease. It occurs in very old people over the age of 80. It's associated with severe hippocampal atrophy and memory loss, so they look like they're developing Alzheimer's disease, but they actually don't have Alzheimer's disease pathology. It's a TDP43 pathology. So we think that's what's going on in this particular case. Molecular imaging in AD clinical trials, well, it helps you improve selection of subjects. You've got to make sure people have got amyloid before you give them anti-amyloid therapies. It's enabled us to identify people in the earlier phase. Now you don't have to wait for dementia to make a diagnosis and get them into trials. We can now even get people into trials who are on the pathway before symptoms, so-called preclinical AD, and it can also show whether the medications are working. You can use it to measure whether the amyloid's being cleared out of the brain, or the tau. So there's anti-amyloid antibodies and there's anti-tau antibodies that are in clinical trials. Now, early on, there was a lot of disappointment when the first few anti-amyloid antibodies didn't work. But strangely enough, they didn't use amyloid imaging much to see if they did. They used it in a few people, and when they looked back, well, those anti-amyloid antibodies didn't actually work. There was no clearance from the brain. Then in 2016, out came this work presented at an international meeting using an anti-amyloid antibody called aducanumab, and it worked tremendously. In fact, this antibody can clear amyloid levels back to a negative range within about 18 months of monthly infusions. And interestingly, some data in a large phase 3 study has just been reinterpreted and indicates that it slows the rate of decline in people with mild cognitive impairment or Alzheimer's disease. So this company, Biogen, is now going to the US FDA for marketing approval. Biogen in Australia is starting to prepare for marketing approval application here to the TGA. If this gets approved, it'll have a major impact on the demand for amyloid imaging and the clinical role of amyloid imaging in our community. We are also looking at astrocyte activation with a compound that labels MAO-B, which is seen on activated astrocytes. This is just a bit of another study. We're looking into the neuroinflammatory aspects of Alzheimer's disease. That's another part of the pathology of Alzheimer's disease that creates a bit of a tension and maybe another avenue for therapeutic intervention. So at the moment we have a study running where we're looking at reactive astrocytosis, comparing it to amyloid, comparing it to tau, comparing it to cognition, and following patients over time to see how it does all interact. Summary, and I haven't, nobody's left yet, which is excellent. Thank you for staying. So molecular imaging has and will continue to provide new insights into the pathogenesis of Alzheimer's disease and other dementias. It is the gold standard for target engagement in anti-amyloid clinical trials and for validation of blood tests and other biomarkers. Actually, the blood tests now are looking quite successful. It has diagnostic and management impact. Utilisation, though, is limited by the cost and the lack of a disease-modifying treatment, but that may all change if these anti-amyloid trials, there's currently a lot more going on. If they confirm what the Biogen study showed, and if Biogen is successful in getting marketing approval, I think we'll see the landscape change dramatically. So acknowledge all the people enabled, and thank you for sticking to the end of my talk. Yes, this is me in the Himalayas with my wife. Thank you.
Thank you very much, Chris, for that insightful presentation to your journey here as the Pioneer Lecturer, and also an update on dementia imaging. I would now like to remind everyone about the Attendo Plus app. You can scan that in and register your attendance again. And also, finally, invite Professor Andrew Scott to present Chris with the plaque on behalf of the ANZSNM Federal Council, and pause for some photos.
Okay, here we go. So on behalf of the ANZSNM Federal Council, I'd like to congratulate Chris on his outstanding career. I think he's a very worthy recipient of the Pioneer Lecturer Award. Clearly in the neuroscience area, he's not just leading Australia, but one of the international leaders as well. So we have the little plaque, and I won't shake your hand, but congratulations.
Thank you very much.